Thanks to Mark for starting off the presentation great. And yeah, my name is Joe. I'm a dosimetrist with the team. I've been with Stanford about 5 years now, and I'm gonna share some prostate, IMRT, VMAT, SBRT planning knowledge with everyone. So just some objectives for the discussion. I want to help you guys to understand the planning process from a dosimetrist perspective, from simulation to contouring organs at risk, setting up the plans for VMAT on Eclipse and SBRT, which we've been planning several cases on ViewRay recently, what optimization and tuning structures we will use in different cases, and how they help us achieve conformality, dose homogeneity, and also plan objectives and how we evaluate our plans, and some of the different windows and tools that we use for evaluating VMAT versus SBRT plans, and how those constraints compare to each other. Yeah, so like I mentioned before, most of our conventional treatments at Stanford, we're planning prostate on Eclipse, and we're treating using the TrueBeam linear accelerators, using volumetric modulated arc therapy. That's pretty much our standard for all of our prostate and lymph node, prostate bed and lymph node cases. And then for the prostate SBRT plans, we can also plan them on the VMAT, but we've been recently ticking up the volume on the Meridian, which is our ViewRay planning system. So I will give you guys a little bit of insight into that, just because, yeah, it's been really nice planning on there, and my understanding from the team is that it's pretty advantageous clinically as well. So yeah, just tracking from simulation, the start of the planning process. Our therapist helps set up the patient in the CT simulator. Head first supine with a knee fix and a sponge pad for comfort. Most of the time for our traditional conventional VMAT plans, we're using the umbilicus as a reference point for triangulating our plan and setting our isocenter around. In the Meridian setup on the right, you can see on this slide, the patient has their hands on a ring across their chest, which is above the MR receiver, which is useful for helping reconstruct the images in the region of the pelvis, so that we have a nice, clear, nice resolution for the MR that's captured. So yeah, once that scan is captured, either on the CT simulator or the Meridian machine, we can import the image set into Eclipse, or push it from Meridian to Eclipse, and we can work on some normal contours for organs at risk. Recently, we've had Limbus, which helps us auto-generate contours, and that saves us a lot of time for cases like this. Contouring, anything from rectum, bladder, femoral heads, bowel loops. Usually we'll leave those for the physician to contour in case there's, an area that the physician is looking to spare or is concerned about bowel that's potentially dropping in pretty close to the PTV. And the CT scan is on the top superiorly, and the bottom picture you see is the MRI scan that we're capturing on the Meridian. And you can see right in the center of the PTV volume, or the center of the prostate, we're contouring the urethra, which is important for sparing in our SBRT cases. So that is definitely a contour we'll leave for the physicians to contour. And then, yeah, once we have our PTV approved and our dose provided by the doctor, we'll move on to setting up our plan. So some common fractionation schemes you can see here for intact prostate versus prostate bed. the moderately hypofractionated VMAT treatment, we will use 70.2 gray with nodal region to 52, and the prostate with proximal SVs and margin to 70.2 gray. Conventional IMRT VMAT for prostate goes up to 80 gray and 56 gray for the nodal regions. And then for SBRT, like Mark said as well, we're treating 8 gray per fraction times 5 fractions. So yeah, a little bit tighter margins. You can see 3 to 5 millimeters around the prostate and SVs versus 5 to 7 for conventional or hypofractionated conventional. And then for prostate bed, I actually just planned a case this morning for Mark, and yeah, 70 gray and 35 fractions to the prostate bed plus margin, and 54 gray to the lymph nodes plus margin. So the way we like to set up the plan in Eclipse is usually you can get away with setting up 2 to 3 full arcs, collimated off of 0 degrees, 5 to 10 degrees is usually okay. What we're trying to do is just cover the PTVs that are approved by the physician with a little bit of margin, and not leaving the X-jaws too wide to minimize leakage. And the beam energy we're using for these plans is typically 10x is kind of a sweet spot. Most patients, we don't really need 15x higher energy to achieve the homogeneity and hotspot that we need while planning to spare the OARs, which brings me to the next slide. And most of the time, our toughest objectives that we need to meet in our conventional VMAT planning are the rectum and bladder, which you can see the difference between hypofractionated versus conventional. The rectum, the V50, V65, V40, V65, V50, and V31 for hypofractionated, V72, 65, and 40 gray are all tough to meet on occasion. And the bladder, V50 and 31 for hypofractionated IMRT versus the V65 and V40. Those are all, usually trying to keep the intermediate dose nice and conformal, having the fall off nice, the coverage to the PTV, and still sparing your OARs while being mindful of the bowel in certain cases, as well as the femoral heads. So yeah, you can see the bowel loops, Dmax 55 on hypofractionated and max of 60 on conventional, ideally. Oops. All right, yeah, so this is what our optimization window looks like in VMAT planning in Eclipse. And you can see on the left here, we have our tuning structures, which in this case for lower dose PTV 52, we would crop away from the higher dose PTV. We can set our priorities in hundreds to really maximize that upper and lower dose coverage to get the shoulder nice and steep for the PTVs, to keep the coverage nice and homogeneous, as well as not too hot, which is an advantage of the SBRT. We can really keep it nice and conformal and keep those hot spots in the 110 to 115 range. And you can see below on the left, the bladder, we can do upper objectives or volumetric objectives, as well as using the mean to really pull those OARs and keep the conformality on the PTV coverage versus sparing our OARs. Yeah, and we use this for, bladder, rectum, femoral heads, bowel. And we just use that priority to kind of gauge how important we need to push one OAR versus another against the PTV coverage. So the way that we evaluate the plan after it moves through the optimizer and runs through calculation is using DVH, which Mark already highlighted for us. This is a DVH in Eclipse that we use to evaluate a hypofractionated case with prostate and lymph nodes, 270 by 26. And like I said, we're trying to maximize that coverage around that 54 gray area here, 95%, as well as the 70 gray, 95% coverage here, while sparing the OARs, which you can see the bladder and rectum colored yellow and green down to the left. Yeah, and this is an absolute dose. Another way we can do that is by using our plan objectives tab, which gives us a nice, easy way for dosimetry and docs to communicate and evaluate constraints to the PTVs, OARs quickly. If one of these is not met, you'll see any one of those green boxes flashing red, and it's just important before we kick the plan off to the physician to verify that all of these constraints are entered correctly and that they make sense based on the fractionation that we're using for each patient. So it's definitely a useful tool in Eclipse. And I actually used our auto planning script today, and this has been a pretty helpful addition to prostate planning, so that we can define all of our parameters for the machine, beam energy calculation model on the left, and dose, and then we can import one of the templates on the right, and then we can have it auto-generate all of the tuning structures and additional optimization structures that we need in the middle, and then we can run a plan in the background and review the plan for all of the quality measures at the end. And yeah, I used it this morning on that prostate bed and lymph node case, and then tweaked it manually afterwards, and it was it's been a really useful tool. And this just shows the comparison of some of the auto-planned prostate cases in Eclipse versus the manually planned cases. So we can see that there is some pretty significant improvement in the high dose sparing to the bladder, rectum, for the V70, 75, 65, and 60, and it's definitely pretty substantial. You can see in the DVH there the square manual plan versus the triangular auto plan for the rectum. It really does a nice job with the rings that it generates to spare and really carve the dose posteriorly, as well as maintaining that coverage to the PTV. So yeah, just briefly, the way we're setting up our SBRT plans in ViewRay is similar to step and shoot IMRT effectively. We're using around 25 to 35 static beams and avoiding entering through the couch edge, which you can see here in this picture. And our beam energy that we're using in ViewRay is 6x FFF. Some tuning structures that we'll manually create and generate rules for in ViewRay. We will crop the rectum and bladder about a cm from the PTV. We can use a ring, which is highlighted in pink here, which is 2 cm thick and 2 cm cropped from the PTV as well, to kind of keep that 50% dose nice and conformal. And if we needed to, we could crop the PTV 1 millimeter from the rectum or the urethra if we were having trouble meeting the 105% dose max constraint. But usually we can get away with this by just keeping the plan nice and cool using the optimizer. So yeah, this is on the right. This is what the optimizer looks like in ViewRay, and we have our constraints at the bottom there in the objectives tab, PTV new. So we're only using decreased dose or increased dose, which is similar to the upper and lower objectives. We use the importance and power to gauge how hard we want the optimizer to push the PTV versus constraints like the urethra or the rectum. And it's a little bit different style of planning because we're only pushing maximum constraints. So we can only tell it we want to minimize the dose based on a maximum dose constraint there, which is the threshold on the right. So you can see the urethra, realistically, we want the max to be less than 105% point dose, which is 42 gray. And in the optimizer, I'm telling it to a max of 37. And in SBRT planning, the most important things we're considering and have difficulty meeting are those higher dose max constraints to the rectum, bladder, and urethra, and the V36, 38, and 40 volumetric constraints for the rectum and bladder. Or sorry, just the rectum. Yeah, the bladder is the max dose, and then the volumetrics are 36, 32, and 21 gray. So mindful of the 50% isodose line as well, like I mentioned with that tuning structure for the ring. And yeah, this allows us to keep a really nice conformal plan. You can see here in ViewRay, similar to what Mark was highlighting before. And then we can evaluate in ViewRay pretty similarly to Eclipse, and we have an evaluation tab here where we're comparing everything that we enter in the RX tab to what the plan is delivering us based on the constraints that we put in. And we can see here if there's nothing, I think it's colored orange or red that's flashing out at us, then this means that everything is meeting. And it's important to double check this as well before we start planning and kicking off to the physician, just to make sure that all of the constraints and objectives make sense based on, what fractionation we're using, which in the SBRT cases on ViewRay is 8 gray and 5 fractions. And once the physician approves the plan and all the objectives are met, we can, whether it's Eclipse or ViewRay, here we have a little snippet into what the KV-CBCT, which is done before each fraction in conventional treatment on Eclipse, looks like. So we have the fiducial markers, which you can see on the KV, and then the CBCT is taken, and based on those fiducial markers and the surrounding soft tissue, make sure it makes sense, and then apply the shifts based on how it looks on the fusion here. So yeah, the CBCT is really useful on the TrueBeam machine. So, and then in this case, this is what the live treatment on ViewRay would look like. So here we have in the red is our tracking structure, or our PTV, and then around it, that yellow margin is pretty much acting as a guide for gating. So you can see in the bottom left here, it'll say gating on, beam off as I press play. Or maybe I can't press play. Here we go. So yeah, you can see the red in the center, which is our tracking structure, our PTV. We want it to stay inside the yellow boundary. And the threshold is 3 millimeters, and the other part of this gating, which you can see in the bottom left, is the beam is turning on and off because of the various fields rotating around like step and shoot. If 5% of the PTV moves outside of that yellow margin, then the beam will also shut off. So kind of two different built-in measures to gate the plan on ViewRay. Yeah, and you can see that fiducials are not necessary either in the ViewRay, and this is really reproducible in on the meridian with the an enema used for the rectum and the full bladder, which is similar to VMAT as well. And yeah, not having to use those fiducials is really nice, and this gating feature is a really reliable way to treat on ViewRay. So. And that's it. That's prostate and VMAT planning, SBRT planning in a pinch. I guess I was a little bit over, but yeah, thank you all. And yeah, this is a disc golf course near me in the autumn.
Thank you so much, Joe. Nice picture.
Yeah.
So I'll open up the floor for questions. You can turn on your camera and start asking a question, or you can put the question in the chat if you want.
Hello, I'm Zoya Shepel, oncologist from Kyiv. In our country, unfortunately, we had many patients whom diagnosed third and first stage of the disease. According the information our cancer register on 2021, we had more than 50% of advanced cases of disease. And frequently we use conventional radiotherapy because case of disease our patient is advanced, and we have not MRI linac, and we have not brachytherapy, unfortunately, in our country. And I want to ask you about moderate hypofractionation because it's more usable for us. What we must be convent on our treatment plan. What margin you recommend when we do moderate hypofractionation? It's no, because we also have not gating in our clinic, and we use more biggest margin for do our plan. It's maybe 1 centimeters. What you think about this? Or maybe you think what we must do conventional treatment because what we take a successful result.
Mark, do you want to take
Yeah,
that one?
yeah, I can definitely field that question. What do you have capabilities to do cone beam CT?
Yes, we do.
Okay. How do you do the matching? Is the matching done manually, or is it done by a therapist? Is it done by the doctor? Is it done automatically?
No, we have a team who doctor and medical physicist and the RTT and we place the patient and have do CBCT every day.
Yeah. Do you look at the CBCT prior to each treatment?
No, yes, we look.
Does the doctor, does the therapist, what's the process?
No, first fraction with doctor and medical physicist. For other fraction, if the placement is good, it's do RTT.
Okay. What I would advise you to do would be to consider a fractionation that was used in the Fox Chase randomized trial of moderate hypofractionation, published in the JCO, first author Pollock. And what that uses is 8 millimeters all around, except 5 posteriorly.
Mm-hmm.
Okay.
And Mark, remind us,
hold
so
on.
that was to prostate 70.2 gray, right?
70.2 and 26 fractions. That's right.
Yeah. Mm-hmm.
And so just give me a second.
Yeah.
I'm going to share my screen, okay?
Mm-hmm. Yep.
Okay. Can you see that?
Yeah. Mm-hmm.
Great. So this is the reference, okay?
Mm-hmm.
And what it showed was compared to 76 and 38 fractions, there was no difference in biochemical control or toxicity. Okay, JCO 2013. And what I want to show you further is I participated in the moderate hypofractionation, in the hypofractionation guidelines for Astro a few years ago, and was in charge of writing and organizing the technique section, including the dose constraints. And so what this figure shows is it's a scatter plot of the various dose constraints that have been used for moderate hypofractionation. Okay. And you can see the Fox Chase dose constraints here in orange. Okay. And the purpose of me showing you this is that they are the strictest rectal dose constraints used for moderate hypofractionation. And so I think that should give you some confidence moving forward with that technique and fractionation schedule, because it was exactly that what was used. Now, the only difference being, when this trial was done, we were using the BAT ultrasound for daily image guidance. So that's transabdominal ultrasound. I don't know if you're familiar with that. It's an older technology. It's been retired. It's in the technology hall of fame. And I think cone beam does a much better job. I have a lot of experience with both, and I've been really impressed with modern cone beam technology and its ability to fuse. So I would think your ability to do daily IGRT would be at least as good, if not better, with cone beam. So, yeah, does that answer your question?
Thank you very much for lectures, and it's very usable for us and very interesting. Thank you so for your time.
You're welcome.
So I also have a question.
Mm-hmm.
What is your opinion about SBRT for high-risk prostate cancer?
So, yeah. That's a good question. It's a very good question. You know, let me pull up the other slide set real quick so I can respond to you with a slide as well. So I personally don't use SBRT for high-risk clinically localized prostate cancer. I use it for favorable and intermediate when appropriate. UCLA has participated in a consortium of treating high-risk patients with SBRT. And these are the results here. It was published in the Red Journal in 2022. And it's a mixed, it's highly selected patients, varieties of treatments. 20% of patients got lymph node treatment. 3/4 of patients got hormone therapy. You know, here are the kind of like, you know, cohort results in terms of PSA failure and freedom from metastasis. The Astro hypofractionation guidelines advise against treating high-risk prostate cancer with SBRT outside of a clinical trial. And I endorse that recommendation. I think it should be done with caution. Yeah.
Okay, thank you. And the second question about contouring and CTV for SBRT prostate. When you include proximal seminal vesicles, so is it 1 centimeter or 2 centimeter, and how do you add it? Like just expanding prostate 1 centimeter and just crop, or
Yeah,
or
great
include?
question. Great question. This is a common area of confusion among radiation oncologists, trainees, fellows. And how I've come to understand it is rooted in my experience doing brachytherapy. I think the prevailing idea is that the seminal vesicles are like bunny ears on the prostate. That, you know, they're like little, like Mickey Mouse ears on top, and then you have to go a centimeter above the prostate or 2 centimeters. And what I've learned doing brachytherapy is that the seminal vesicles as really originate much lower down, down here on the prostate. And then you can almost see them on this ultrasound if you read a lot of ultrasounds, but you know, they're originating down here, okay? Surgical pathology series explain that seminal vesicle invasion in clinically uninvolved seminal vesicles can be like 7 millimeters, which is why a 1 centimeter has been a convention in defining the proximal seminal vesicles. But I think for the way we contour, that 1 centimeter is often included in the contouring of the base. And it need not start at the top of the prostate and go 1 centimeter up and then 2 centimeters up. My concern is that dogmatically going 1 centimeter or 2 centimeters above the prostate is needlessly exposing rectum and sometimes the sigmoid, which can hang low behind the bladder in some patients. I don't know why my mouse isn't working that great, but sometimes, you know, sigmoid can be down here too. And then folks are chasing seminal vesicles, you know, because it says do 1 centimeter or do 2 centimeters, and you're counting slices on the axial or measuring on the sagittal. So I think you can use good judgment on a case-by-case basis and individualize what you think the 1 centimeter is in cases where there's no evidence of seminal vesicle invasion. Okay, it's an insurance policy of seminal vesicle treatment. So just use good judgment and don't overexpose the rectum by being dogmatic, counting 1 or 2 centimeters. Does that help?
That is so helpful, and this was such a wonderful lecture.
Okay.
I had a quick question. Would you consider including more of the seminal vesicles in higher risk patients?
Yes. Yes.
The entire seminal vesicle?
There's an argument for that, but I would not cover the entire seminal vesicles at the cost of meeting my rectal dose constraints or sparing the sigmoid bowel. I'm much more, over the years of my practice, I've come to appreciate more and more staying focused on the disease we know about and less concerned about addressing future possible risks of things that we don't, that are not a problem today.
Thank you.
And you know, I think patients appreciate that approach. At least you know, the culture and the condition of practice in the United States is we do a lot of covering bases and applying insurance policies of treatment, and I think the public is acutely aware of that and seem very skeptical at times about intensification of treatment and application of adjuvant therapies or adjuvant treatments because of the potential for toxicity. So it is a bit of a balancing act.
Thank you, Mark.
Yeah.
Any more questions? One more question and we can end the session.
Good afternoon. Thank you very much for the brilliant lections. And I have actually two questions. First of all, what about the drinking protocol for SBRT and hypofractionation and your attitude to the rectal spacers?
Did you say drinking protocol?
That's what I heard.
Yes.
Oh,
Yeah.
okay.
Yeah. So how it works is, you know, we tell patients to drink, you know, I think a half a liter 30 minutes before treatment so that they have a non-empty bladder. My objective is not a full bladder, but a reproducible non-empty bladder. And so in practice, this requires a fair amount of coaching and education, you know, of what exactly that means, so that and how and the fundamental tool to do that is the cone beam CT. So I like using daily cone beams because it provides the therapists some opportunity to give the feedback to the patient about how full or how empty their bladder is on any given day, so that they can alter the amount they drink and the timing that they drink it prior to the treatment to provide consistency and adequate filling. Is it? Yeah. And
The
then
second question, spacers.
Spacers.
Yeah.
Spacers provide an insurance policy with regard to the dosimetry. Okay. I'm thinking, I'm being thoughtful. So based on level of experience, I think spacer use should be individualized. I don't routinely use rectal spacers. I don't feel that I need a rectal spacer to ensure adequate rectal sparing, given the level of experience, technology, and tools available, the experience and volume of experience of the staff. I don't think that is an insurance policy and a procedure that patients need to undergo to keep the radiation therapy safe and acceptable.
Yes.
Under different circumstances, it might be.
And can I have a last question about hip prosthesis? Have you treated such patients, especially with bilateral hip prosthesis? Because the metal gives us artificials, and we have the
Artifacts.
dark artifacts. Thank
Yeah.
you. And we have a dark hole between the hips in case of bilateral hip prosthesis.
Yes. It is routine practice for us to do an MR sim as well. And so for patients with hip prosthesis, I would encourage you to get an MR simulation.
I have no,
It is not, I'm sorry, I didn't hear you.
have no MRL Linux.
You don't need an MR Linac. You don't need an MR Linac. And it doesn't need, you can get a regular diagnostic MR and request a small field of view, high resolution T2 prostate MRI. Okay, so high resolution, small field of view, T2 prostate MRI, you don't need contrast. And what you can do is you can fuse that MRI to the CT. And then you can do your contouring on the MRI. I may be able to show you a quick example of that in 1 second. Take me about 1 second.
So in terms of planning, what we typically do when we do VMAT, we put avoidance sectors around the prosthesis with some margin, so the beams are not going through the prosthesis. And we always use lower energies like 6x, or we do not use 10x in those cases, because it's more accurate in terms of the symmetry, and it doesn't create neutrons.
Thank you.
But the plan quality usually suffers in bilateral prosthesis, so it's difficult to spare rectum, spare bladder in those cases.
Yes, indeed.
Yeah, so if this is what you're referring to over here, right?
Yeah.
It's black for sure.
Mm-hmm.
But if you get the MR, there's still a little MR artifact. But wow, but I mean, it's night and day, and you'll be able to, confidently, see the rectum. You should be able to reassure yourself that you're defining the rectum appropriately. You'll have much better visibility to the prostate. And this is, again, a high field T2, small field of view, prostate MR, no contrast. And you'll want a couple larger field of views so that you can do the fusion.
Mm-hmm.
Physics will need that to do the fusion to the CT. You'll need the hips and the bones and all that jazz.
Mm-hmm.
So there's a few series, but they don't need to do a whole series. It doesn't need to be 45 minutes of MRI.
Mm-hmm.
You can tell them to keep it quick, like 20 minutes.
Okay,
And
thank you very
then
much.
what's important, what will be important, this is important. It is routine and customary when they do diagnostic MRI to tell the patients to pee before they get on the machine. Because it always takes 45 minutes and patients have to go to the bathroom. So they have them empty their bladder first.
Right.
So you want to give them specific instructions. Do not tell the patient to pee. You give them the same drinking instructions you would give them for doing the CT sim. And then it should be great.
Awesome. Thank you, Mark. You answered all the questions with slides. That's impressive.
Yeah.
Thank you. Okay, we'll
You're welcome.
finish up the session. It was excellent session, great speakers, great talks, and we will be translating those into Ukrainian, posting it on the website. And our next session will be on Wednesday on LAN IMRT SBRT. Till Wednesday. Bye, everyone.
Thank you,
Thank
Natalia.
you.
Thank you.